Good morning. My name's Anthony Silver. I'm the founder and director of Grey Matters. And this morning's presentation is on the three-dimensional EEG evaluation of brain networks. So I believe that it's very important as clinicians that we question everything we do. Our job is to improve outcomes, not just to embrace new technology. It's not enough to say that we evaluate and treat the brain from a network perspective. We need to ask the question, why? Why do we use 19-channel QEEG to identify dysregulated brain networks and neurofeedback to treat them, when QEEG often shows relatively localized areas of dysregulation? We should ask ourselves, is there a clinical benefit to the patient from this perspective? Is there an improvement in outcomes? I think this is especially relevant as we know that localization of function is so specific. It was demonstrated by Paul Broca over a century ago, by Carl Wernicke, and in more detail by Corbinian Brodmann, and I guess more colorfully by Phineas Gage, who left part of his frontal lobes next to the railway track he was working on after blowing a tamping iron through his prefrontal lobes, becoming, according to his physician, John Harlow, fitful, irreverent, capricious, and vacillating. Thoroughly unpleasant, clearly. But the question is particularly relevant now as the localization of brain function has become so sophisticated, especially with new imaging techniques such as fMRI, SPECT, PET, DTI, and of course QEEG. For me, this question is best answered by another clinician who described neurofeedback as like playing whack-a-mole, that when you train down one dysregulated area, another one pops up. So this is because location-based training often targets a compensatory issue and not the underlying cause. This clinician was chasing around dysregulation while other compensatory issues by necessity had to appear. But we know that the brain is an extremely intricately connected organ. And we understand after the 1990s and the decade of the brain and the cross-validation between different functional methods that these different brain areas work together to form distinct functional networks. So these are the brain networks identified and cross-validated with all these different brain imaging techniques, and these are the functional brain networks used in NeuroGuide. What we're going to talk about today is training using the default mode network. The default mode network is the brain's largest and most foundational network. It becomes deactivated during cognitive, goal-directed tasks and activated at rest, with differences in the default mode network strongly linked to a variety of disorders, including Alzheimer's, autism, schizophrenia, bipolar, post-traumatic stress disorder, depression, and many more. The default mode network's role in normal brain function arousal is why it was chosen for neurofeedback training for Ian, the case study I'd like to present today. So Ian came to us in December 2022. He's 17 years old, suffering from severe depression, anxiety, and social withdrawal. He began seeing a therapist just previously in the fall of 2022 and referred to a psychiatrist who prescribed Paxil. 2 weeks later, Ian was hospitalized for mania. It was during this time and in a PP immediately afterwards that Ian revealed a history of repeated sexual abuse. So This is Ian's brain pre-neurofeedback at 5 Hertz, showing significant under-arousal, measuring 2.46 standard deviations from the norm at 5 Hertz, 3.73 standard deviations from the norm at 7 Hertz, again at Brodmann area 23, the posterior cingulate. Over-arousal in the posterior cingulate at 14 Hertz, measuring 3.49 standard deviations, and 3.53 at 15 Hertz. So clearly Ian was extremely dysregulated, both sedated and over-aroused. This is Ian's brain compared to pre and post neurofeedback after 30 sessions of swLORETA neurofeedback. So we're going from December to February with 30 sessions. At 5 Hertz, going from 2.46 standard deviations from the norm to 1.81. At 7 Hertz, from 3.73 to 2.01. 14 Hertz, 3.49 to 0.39. And at 14 Hertz, 3.5 standard deviations from the norm to under half a standard deviation from the norm. This is Ian's default mode coherence in theta, greater than 1 2/3 standard deviations from the norm, completely normalized after 30 sessions of swLORETA neurofeedback. And EEG coherence in beta 2, dramatically improved. So to go back to the original question, why do we treat the brain as a networked organ? So on the day of Ian's last assessment, February 13th, 2023, Ian had his first day at school. In fact, this assessment was taken at the end of the day, and he'd done well, had a good day at school. And I'm pleased to report that now, as we speak, Ian has just completed his first week back at high school and is doing very well, and that his treatment is ongoing. So what we find, and what I hope this has shown, is that training the brain as a networked organ, as opposed to chasing localized areas of dysregulation, or playing whack-a-mole with them, can produce really profound, life-changing results relatively quickly. And that rather than chasing dysregulation around the brain, we are systemically improving function. Thank you very much.